Thank you so much for having me here. I want to acknowledge the team and co-authors. So in my 10 minutes, I'll be going over the background and methods, findings, and ways forward. So we have over 117 million forcibly displaced people in the world today, and Uganda is the largest refugee hosting nation in Africa with more than 1.5 million refugees. Where you see the blue arrow at the top of the map on the right is where the study took place, which is Bidi refugee settlement, one of the world's largest refugee settlements with over 190,000 people. And humanitarian settings have health centers and health infrastructure that is often under-resourced and constrained access, testing, supply stockouts, medication stockouts. And so strategies such as HIV self-testing offer promise and potential for addressing some of the access barriers to HIV testing in humanitarian settings. However, there's a almost complete lack of evidence on HIV self-testing in humanitarian settings. So this is something I've been working on as a guideline development group member with the WHO on their self-care strategies for sexual and reproductive health. And we recently published our findings from a mobile health, our Tushirikiane HIV self-testing study with urban refugee youth in Kampala. But to date, this might be, as we know, one of the first studies in an actual refugee settlement of HIV self-testing. And so why comics? So graphic medicine has been used for health promotion, including in HIV, and we successfully implemented a comic book post-rape care and sexual violence prevention intervention in Bidi. It was so successful and accepted that youth were making copies to hand out to their friends. And right now, our colleagues at Uganda Refugee and Disaster Management Council are using the same comic on another funded project. So it's great. It's open access online. You can download it from our website. And so our study protocol is published and involved a formative phase with qualitative data collection, followed by a 3-day human-centered design workshop with peer navigators, comic book development, and a trial. So in brief, we conducted 4 focus groups with refugee youth, 2 with young women, 16 to 19, and 20 to 24, and 2 with young men, same age categories. We developed a comic book that was aligned with the HIV prevention cascade dimensions of motivation, access, and effective use. And then we had an RCT with one arm with the self-testing and comic, one with the self-testing alone, one with the comic alone, and one with standard of care. We collected data, a baseline and 3-month follow-up. 4 villages from 2 zones in BDBD were selected and randomized to one of the study arms. We used peer-driven and convenient sampling with URDMC, as well as 8 peer navigators who are refugees. Inclusion criteria was being aged 16 to 24, living in one of the villages, identifying as refugee, and speaking and reading at least one study language, English, Bari, or Juba Arabic. Self-test arms received 2 kits with verbal, written, and visual instructions, and comic arms received a hard copy of the comic book in their preferred language and met with a peer navigator to read the comic together and create dialogue on blank pages as part of our participatory comic approach. So we examined HIV testing uptake in 2 ways. So our main outcome was if they had a test at time 2 compared to time 1. Is this thunder for this presentation? So of course we had to look at those who were tested in the past and those who were getting their first test or a new test. And we had secondary outcomes of HIV and adolescent stigma, HIV knowledge, safer sex efficacy, and sexual relationship power. We used generalized estimating equation models, including unadjusted and adjusted analyses for our relevant outcomes, including HIV testing at baseline, pre-specified covariates, and covariates that were imbalanced at baseline across study arms, and we used intention to treat methods. And so this is a snapshot of our qualitative findings, where you can see our findings spanning motivation, access, and effective use. For instance, motivation was shaped by risk perception and social norms around gender and age. Access included limited availability of testing supplies and stockouts, distance to clinics, and effective use was shaped by inequitable power dynamics and relationships. I'm just giving you a snapshot of some of the pages from our 9-page comic, which is meant to reflect the context of Bidi Bidi. And so these are some on HIV testing access, partner testing dynamics, and assessing one's relationship and the risk of violence in one's relationship if one was to engage in testing, which youth recommended, and self-efficacy and living positively with HIV. And so what did we find? So we had 120 youth randomized across these 4 arms. So we had 98% retention, which is pretty awesome and shows, the value of community-based research. And we had 120 participants, half young women and half young men. Mean age was 20. 32% had children. 69% had lived in Uganda for 6 to 10 years. 3/4 had a lifetime HIV test at baseline. This was significantly different between study arms, and I'll be showing you that figure. Very few had completed secondary school as their highest level of education, only 10%, and 34% had less than primary school. This is really indicative of the profound impact that conflict and migration has on adolescents and youth. You saw 45% were dating, 27% casual dating, 20% married, and there were other baseline differences between study arms. So adjusting for age, gender, time in Uganda, vaginal sex history, condom use at last sex, and baseline HIV testing, the odds of HIV testing at time 2, so change in testing from baseline to time 2, were highest in the HIV self-testing kit plus comic arm compared to standard of care, followed by the comic alone arm compared to standard of care. There's actually no significant difference in HIV testing between the self-test kit alone and standard of care arms. Almost all youth had tested by the end of our study at time 2. Of these, 25% reported a new test at time 2, and 74% remaining had a repeat test. 89%, and we could talk about this later, went for a clinic-based confirmatory test, which were all confirmed negative. And you can see the odds ratio, adjusted odds ratio for the comic versus standard of care was 4.14, and the self-test plus the comic was 8.46. There were really significant differences in baseline testing. We can talk about that. The social organization and social cultural differences within refugee and between refugee communities is often understudied and create some challenges in study design. We also found that the self-test plus comic arm are more likely to ask for support when using the test kit from a peer, a family, or partner, and were more likely to use a kit at home versus those getting the self-test kit alone. We had no difference by intervention arms in our secondary outcomes. We also looked at some qualitative findings on the implementation by asking at time 2, why did you get a confirmatory test if you tested negative using the self-test kit, and anything they wanted to share about the self-test kit and comic book, using the CFR and thematic analysis to look at implementation and innovation outcomes. Implementation outcomes included a mistrust of oral testing for HIV versus testing blood, a mistrust of the self-test results, low HIV self-testing self-efficacy, and also high acceptability with privacy and convenience. With the innovation impact, the self-testing and comics increased confidence to engage in testing, increased knowledge of testing and prevention, increased acceptance and support towards people with HIV, and people were motivated to share the comics with others. So ways forward, HIV self-testing accompanied by comics holds promise in meeting refugee youth testing needs in a large rural Ugandan refugee settlement, and these benefits have not been extended to humanitarian contexts at large. However, there's some considerations and lingering questions. There were no significant changes in HIV stigma or adolescent sexual and reproductive health stigma for the intervention arms. Was the comic perceived and described as helpful, but insufficient on its own to dismantle entrenched stigma? Could we have used other measures to better capture HIV stigma dimensions that may have shifted, such as internalized stigma? And those with the comic and self-testing were more likely to access support when using the self-test kits versus just the self-test kit alone. Does this reflect reduced disclosure concerns, a facet of stigma, or did the comics facilitate how to talk about HIV testing with others? And do we need more prevention literacy work in HIV self-testing in humanitarian settings to reduce the burden of confirmatory testing on these under-resourced clinics and humanitarian settings? And Other considerations in my last 10 seconds, there's social ecologies we can consider, intersecting stigma and gender inequity, and participatory, creative, and violence-aware approaches to support youth-centered HIV testing. And my 10 minutes is done. Perfect. And acknowledging everybody.